We can go on to the next speaker. That's
Talking about my thesis, that is managing post-SFIL retinal detachment, functional and anatomical outcomes. I have done a thesis under the guidance of Dr. Pramod Bende sir, and my co-guide was Dr. Shobit. So recombinous retinal detachment is one of the most serious complications after IOL implantation surgery. Management of pseudophakic RRD differs from phakic RRD, as often there are chances of missing retinal breaks in the peripheral area due to the visualization difficulties. So my primary objective was to analyze the anatomical and functional outcomes of retinal detachment surgery post-SFIL implantation, and my secondary objective was to identify the intraoperative difficulties or modification needed during surgical procedure while managing these cases. It was a retrospective study done in the Medical Research Foundation, Shankar Nethralaya, Chennai, from January 1999 to December 2021. The study population of patients visiting Shankar Nethralaya and fulfilling the inclusion criteria. Retrospective retrieval of data was done using the approval of IRB board at Shankar Nethralaya. The inclusion criteria were patients who develop retinal detachment following SFIL surgery during the surgery period and have a minimum follow of 2 months post RD surgery. The exclusion criteria was all the patients who had other retinal disorders before developing RD, which can affect the final outcome. Moving on to the result and discussion, it will be discussed under the following headings: preoperative evaluation, intraoperative findings, and postoperative findings. It was a retrospective study over a period of 22 years, having 4,529 eyes which underwent SFL implantation. 34 eyes of 32 patients developed post-SFL retinal detachment. So the incidence we found was 0.75%. This is a comparison data sheet with other studies of sample size of more than 100 eyes. The incidence was a little less in our study, probably because of the meticulous peripheral base shaving during the pars plana vitrectomy for SFL implantation and majority number of eyes. Moving on to the history, the main indication of SFL implantation in our study was congenital subluxation of lens. Usually eyes with congenital subluxation of lens are at higher risk of developing RRD, but the difference was not statistically significant in our study. Also, we found no co-association between the site of entry of needle and the location of breaks in our study, as was proposed by the study by Lee et al. In our study, only 20% of the eyes had PVR at presentation, which is less as compared to the literature. This can be because mainly of two reasons. First, the early presentation of the patient in our series. Second, majority of the breaks were atrophic in our cases compared to the horseshoe tear in other studies. Intraoperatively, all of our eyes underwent pars plana vitrectomy. 4 eyes needed additional scleral buckle to support the unrelieved traction. The silicone oil was used in 52% of the cases, while C3F8 was used in 47% of the cases for internal tamponade. This is a screenshot of all the eyes which underwent the procedure and how the whole procedure went through. The anatomical outcomes were the mean follow-up period was 56.7 months. The single surgery success rate was 85.2%, and the final surgery rate was 91.1%, which was slightly higher than the known in the literature. The visual outcomes were at the final follow-up had improved vision in 73.5% of the eyes. We also find a positive correlation between the visual outcomes post-retinal detachment surgery and the indication of SFIL in our study. Visual outcomes were better in eyes where SFIL implantation was done for surgical aphakia, p-value 0.027. Also, non-traumatic subluxated lens had a better visual outcome as compared to a traumatic lens subluxation for the indication of SFIL. So to conclude, though not very common, RRD is a very vision-threatening complication for post-SFIL surgery. The incidence in our report was 0.75%. Thorough fundus evaluation and treatment of all peripheral lesions before SFIL implantation surgery may reduce the incidence of post-SFIL RRD. Location and breaks may not be necessarily correlated with the fixation sutures. Complete vitrectomy with peripheral base shaving should be done during SFIL implantation. Pars plana approach is preferred in these cases, which helps to remove the performing good base shaving as well as removing the residual vitreous. There are some unique difficulties a surgeon face while operating these eyes, and like the condensation of the posterior surface of the eye during the fluid gas exchange and the air entry during the FGE. Surgical explantation almost never needed in these eyes. The etiology of SFIL implantation was never may impact the final outcome, and these are my following my limitations, my references. Thank you.
Doing SFIL, what type of SFIL you are?
In all of the 34 cases which we did, it was a sutured SFIL, 4-point fixation.
Sutured with a Prolene suture, na?
Yes.
Yeah, double suture or single suture?
It was a Gore-Tex sutures which was used, and it was like 4-point fixation was done.
Okay. But you are not doing any tucking or multi-disc lens?
We included only sutured SFIL in our case series.
Okay.
Because we were during the surgical one of our findings were we don't need to explant the SFIL because they are mostly stable. Out of the 34 eyes, only 2 eyes we had to explant the IOL, which were already subluxated at the time of presentation.
And only you are not mentioned what types of RD? It is a fresh RD or old RD? of the subtotal RD or a total RD?
One of the chart I showed, we had presentation, 61% of the patients were having more than 3/4 involved at the time of presentation with us. So this was again one of the finding that post-vitrectomized eyes have an earlier presentation, which cause less chances of PVR changes, and then finally we will have a better functional outcomes.
After how many days that RDs happen after the SFI?
Usually in our series we found at a minimum of 15 days, earliest as 15 days, and as long as 5 years.
And what is your result after doing RD surgery? Getting
do-
external buckling or internal? External approach or internal approach?
No, it was always the internal approach. We always use pars-plana vitrectomy because almost all eyes were partially vitrectomized or anterior vitrectomy was done while most important thing is while doing RD surgery in SFIL cases, there is a lot of visualization disturbances because of edge effect. So it's better, we might miss retinal breaks pre-operatively. So it is better to do it at internal approach so that we can see the breaks, which was seen in our study, like 29% of the breaks were not seen pre-operatively, but on table we could see it and we could laser it.
IOL is still in place
Yes.
after doing so. It's
Yes.
okay.
Yes.
I just wanted to understand if this is your thesis, right?
Yes.
So how did you recruit the patients? Because were these the 34 patients that came during your 2 years? Or these were the 4,500 patients retrospectively? We usually in thesis, we give a, I mean, we don't like do a retrospective study where the student doesn't have to do anything.
So this
Like,
was a
that is a little.
this was a retrospective study. So it was 19 years in the past and 1 year, 2 years in the in forward, like from 2020 to 2021.
So the 4,500 was
Is from
data
1999 because the sample size was too less. The incidence of the disease is like in the literature is also reported in 1 to 3%.
So during your 2 years, how many surgeries did you see? Is what we
Surgeries,
teachers are interested in, I think.
Okay, so the cases which were during my residency were 8, but out of that the surgery I could see, because I was posted at a time, I could see only 3 of the surgeries being done.
So most of your thesis work was paperwork.
A lot of it was.
Is what we really have to think about when we give
But I
thesis.
think if you are looking at a topics where the incidence is very low and your subject duration is only 3 years, so you have to do a lot of paperwork to get that data. Because in this study we were able to also say that we should do a complete vitrectomy at the time of SFIL implantation rather than just doing an anterior vitrectomy, because most of the results are much better after that.
So I don't refute the nature of the study, but my concern was the thesis part.
This is the suture arrival is most of the surgeons they are doing a tucking with a multiple lens. That is much more stable. Suture will always have a vibration each movement of the eyeball. That may leads to a retinal detachment also. No?
What are the statistics used?
So multiple statistical methods were used, like the most common was chi-square method was used, and there were 2 more statistical regression methods which were used to compare between the groups having anterior vitrectomy versus complete vitrectomy, between the comparison between the attached location of tears, what type of tears between the different studies. So multiple regression studies were also used.
What were your basic outcomes like? What are the outcome measures in your study like? What are you looking at basically?
So we are looking at a couple of things, like first 79% of the cases were seen within the first year of SFIL implantation. So a regular follow-up within the first year is very important. First. Second.
No, what I'm asking is
No,
like
is
in
it-
your methodology, what are your outcome measures?
Primary and the secondary outcome.
Yeah.
What was your primary outcome and what are the
my secondary outcomes were we were
Primary?
discussing.
What is your primary? Himesh?
Primary one was commenting about the anatomical and the functional outcomes of retinal detachment surgery post SFIL implantation. The secondary one was looking
So
at.
functional outcome including visual acuity.
Yes.
Okay.
And my secondary was the difficulties which we faced during the surgery of managing RD when there is already an SFIL in place.
So will you use a chi-square test for a visual acuity analysis?
Chi-square, yes, we used for the visual acuity analysis also.
Okay.
It's
Usually you can't because
percentage,
visual acuity is not a nominal data which can be
Yeah.
analyzed using chi-square
For
test.
percentage and